So now I'm going to talk about some of the pharmacology that we use during medically assisted detoxification. So we're going to be focusing on the pharmacology, but this isn't to think that isn't other things going on during that treatment time. So we need to remember it's not the only component to treatment, but it's something we're going to focus on in this session. And the goal of pharmacological treatment for patients with alcohol use disorder can be abstinence, or it can be reducing alcohol consumption. So it's not necessarily abstinence, but in some patients that will be the goal. When we're thinking about alcohol withdrawal and we're looking at sort of managing patients with alcohol dependence, we need to sort of break this into three sections. We need to be preventing withdrawal symptoms. Once we've detoxed somebody, we then want to be thinking about managing abstinence and supporting abstinence, and then we need to think about medications where we might be using to manage complications in patients. And again, like I've mentioned elsewhere, we need to think about the alcohol withdrawal syndrome, and we're looking for these symptoms. Particularly with patients that might be seeking benzodiazepines and they may show a tremor on their hands, or they might be highly anxious anyway, and this might not be withdrawal. It's useful to look at symptoms like tremor on their eyelids, tremor on their tongue, and quite often we see a tremor on the tongue earlier than we see in the hands. So if patients are trying to mask the symptoms or not recognising the symptoms, sometimes seeing a tremor on the tongue is an early sign as well. We need to be looking at the restlessness, we need to be looking at their anxiety, but we need to take that into the context of what are they normally like. Is this more restless, more anxious than they normally are? Are they vomiting? Have they got nausea? Have they got headache? Have they lost appetite? What's the sleep like? And have they got some of the more objective signs like tachycardia, hypertension? And are they experiencing anything that might lead us to think they've got more severe withdrawal, such as auditory visual disturbances, tactile hallucinations, and occasionally if we haven't treated alcohol withdrawal, or they're presenting having gone into alcohol withdrawal without treatment, we might see seizures. And they're rare, but they're usually within the first 24 hours of reduction or cessation from alcohol. And so when we're looking at when these symptoms present, what we tend to find is seizures, if anything, present in the first 24 hours, but the risk is there for at least the first 3 days, if not more. And I have seen seizures at day 7 on one occasion, but that was in a patient with other risk factors, such as medications that lowered the seizure threshold as well. We tend to see the mild withdrawal occurring over the first sort of 3 to 4 days, usually easing off at day 4. So we're generally stabilising the patient in the first 2 or 3 days. But if you if you don't treat someone appropriate and you allow someone to go into more severe withdrawal, that is very difficult to treat, and that can go on for much longer, and it's much harder to bring that down. So that can go on for for many days, even up to 10 days in some patients. So to manage a detoxification, we need to think about the medication we're using for management of prevention of seizures and management of withdrawal symptoms, and prevention of delirium as well. And that would usually be a long-acting benzodiazepine like diazepam or chlordiazepoxide. Most psychiatric units tend to use diazepam. Most acute medical wards tend to use chlordiazepoxide. There's not a great deal of difference. Diazepam has more active metabolites, so it's deemed to be a little bit longer acting, and some of the medics prefer chlordiazepoxide because they feel they can titrate it better. We tend to think about choosing the medication that your team is used to, because the doses are different and they're used to responding to the withdrawal and with a certain dose of medication. So we tend to use the choice of the team, the medication that the team is used to using for alcohol withdrawal, rather than the doctor's decision, medication of choice, because you've got to think about what the team is managing. We're going to talk about Pabranex when we're talking about complications, but we need to be thinking, does the patient need Pabranex, which is high dose B vitamins and C vitamins, and it's looking at, do we need to prevent or treat Wernicke-Korsakoff syndrome, or can we just give oral medication for that? And then we need to think about prevention of treatment of seizures if they do occur. So we're looking at buccal midazolam generally on PRN writing that up in case a seizure occurs. And then from day one, we need to be thinking about relapse prevention medication. Some sites will even give relapse prevention medication because of its, particularly acamprosate, because of its neuroprotective effect. They might give that a week in advance, but generally we want to start that at the beginning of a detoxification regime, and we'll talk about that in a bit more detail as we go on. So this is just to look at a sort of an example of a dosing regime and a fixed dosing regime, and how we might do that. There's, and obviously we need higher doses and a longer period of withdrawal from those doses, reduction of those doses, depending on the severity. And there we're looking at thinking about what dose we need based on how much are they drinking and what's their SADQ score. And this is a nice little tool here. It tells you if the SADQ score is relatively low, and the amount of alcohol, daily alcohol, is relatively low. Obviously 15 to 25 units a day isn't low, but it's relatively low. Then we would start at 10 to 15 milligrams of diazepam QDS. But if the SADQ score and their amount consumed is higher, we would be thinking about choosing higher doses of diazepam, say 15 to 20 milligrams QDS. So, and move on to treatment of decision making about treatment or prophylaxis of Wernicke's. So we have the Wernicke-Korsakoff syndrome, but for this we're looking at Wernicke's itself. And when we're looking at Wernicke's, indications of treatment are the symptoms of Wernicke's. So if you're presenting with any of the symptoms of Wernicke's, you need to be treating as if it is Wernicke's encephalopathy. And the classic triad is confusion, ataxia, ophthalmoplegia and nystagmus. So if we're looking for those three symptoms, though, we will miss a lot of people with Wernicke's. And it's only about 10 to 16% of the population who have Wernicke's present with all three of those key symptoms. So we need to be thinking about Wernicke's if they have any one of that classic triad. And if they have decreased consciousness, hypothermia with hypotension, DTs or hypoglycemia, we need to have a high index of suspicion for Wernicke's as well. And when we're thinking about prophylaxis for Wernicke's, so a different regime of treatment and prevention of Wernicke's in patients that we're detoxing, we need to look for the risk factors for neurological risk, but particularly those ones that we've discussed elsewhere: significant weight loss, poor diet, signs of malnutrition, concurrent illness such as infection, risk of seizures or seizures occurring, and peripheral neuropathy. But for anyone drinking more than 20 units a day, we should be giving prophylaxis doses of Pabrinex for prevention of Wernicke's. So even if they're drinking 20 units a day and don't have any of those other signs, we should be giving prophylactic doses of Pabrinex. And this is as opposed to oral thiamine. If they're drinking under 20 units a day, then we might, and with none of those other risk factors, we might be giving oral thiamine. But generally, oral thiamine is poorly absorbed, so we need to be giving it parenterally if we're giving appropriate prophylaxis or treatment for Wernicke's. If you're low risk of Wernicke's, so drinking under 20 units a day with no other risk factors, we would give oral thiamine at 100 milligrams 3 times a day. You may have seen 300 milligrams, 200, 300 milligrams once a day, but splitting the dose aids absorption. We know that it's poorly absorbed, it's poorly metabolized, and it's poorly stored in patients who are drinking. And that's if they're actually taking it on board in the first place. So we need to make sure that they're getting the most out of the medication dose. So splitting the dose over 3 times a day actually increases the absorption. They get a bigger percentage of that dose if we split the dose over 3 doses rather than 1 dose. If they're at high risk of Wernicke's, so we're looking at, they haven't got Wernicke's, but we're worried that they may get Wernicke's, and they've got the risk factors, they're drinking more than 20 units a day and have all those other symptoms or signs that we've talked about. We need to be thinking about using parenteral high potency B vitamins in the form of Pabrinex, and that we give in two pairs 3 times. 1 pair IM daily for 3 to 5 days. After detoxification, we need to be thinking about how are they getting their diet back? Are they restoring their diet? Are they eating properly? Most patients, once they start detoxing from alcohol, will start eating a bit better. and over time they will establish a normal diet. They need to be given dietary advice about what are the best things to eat. Unfortunately, a lot of the things that have high B vitamins are not necessarily the sort of the sort of diets of choice of some of our patient group. A lot of it is pulses, beans, peas, lentils, things like that. It has high B vitamins. Some fish have high B vitamins as well. So we need to be thinking about, can we introduce that into the diet? Can they establish a normal dietary routine? But we pragmatically will give them thiamine to help them over that the first month until they've really established a good dietary intake. If they've relapsed, we would continue to treat them with thiamine. But if they've established a normal diet and they're abstinent after a month, we would pragmatically say they can stop taking oral thiamine after that. We tend to give now oral thiamine before a detox as well in every patient who's we're looking towards a detox with. So after a detoxification, we need to be thinking about what are we doing. And it's, detoxification is only part of the whole treatment package, as you will see, and there'll be, a lot more of this discussed elsewhere. But we need to be thinking before the detoxification, what are we doing after the detoxification? What is their goal? Is it abstinence? Is it cutting down? What is their goal? How are we going to review and monitor the patient? Are we managing all the other underlying conditions? Are we giving them recovery support? Are we giving them relapse prevention? We need to anticipate relapse. What might trigger this patient to relapse, and how can we prevent it? But to support them, we need to be thinking about relapse prevention medication to support that as well. But it's alongside all those other things that we're thinking about. And we need to be planning that and telling the patient about what we're going to be doing after detoxification before we start detoxification. So I'm now going to talk about relapse prevention medications, and the two sort of key groups of relapse prevention medications are the maintenance group and the deterrent group. Maintenance group used to be called anti-craving group, and we're looking at maintaining abstinence and from alcohol and supporting the reduction of alcohol use and and abstinence from alcohol. Deterrent is a different group, and this is second line, and I'll talk about that in a bit. And this would include things like, this would generally be predominantly anti-abuse, which is disulfiram. All these medications shouldn't be prescribed in isolation. They should always be alongside psychosocial interventions, but the combination of psychotherapy and pharmacotherapy together improves treatment effectiveness in alcohol dependence. And what we need to know is that everybody should be considered for a acamprosate or an naltrexone, and it should be an active decision not to treat rather than a decision to treat. And that the only reasons that we would really not prescribe a acamprosate would be age. They might be too old or too young, or they might have significant liver disease. But if it is somebody who's got moderate liver disease, it's quite often better to prescribe a relapse prevention medication than them to relapse to alcohol. So the sort of key medications I've already touched on are the maintenance medications, the maintenance of relapse prevention, which is acamprosate and naltrexone, and then we've got deterrent medications like disulfiram, and then I'll talk about nalmefene and baclofen as well in a minute. And as I said, the decision not to prescribe these medications should be active. And there's no evidence for long-term use of diazepam. We do know that some people will say, if I'm on diazepam long-term, I won't relapse to alcohol. There's no evidence that that's effective. So acamprosate is a synthetic analogue of GABA. It basically, when you take alcohol away, the brain excitation occurs because you've taken alcohol away, the brain is overexcited, and acamprosate stabilises this. This has a potential neuroprotective effect. And it also has an effect of stabilising the brain to a point that stabilises the brain so that the brain doesn't feel the need to crave or want alcohol, and we don't get the symptoms of this brain excitation that would drive relapse to alcohol. It should be started as soon as possible, as I said, particularly because of the neuroprotective effect that it's meant to have. And some people would prescribe this even a week before detoxification, but generally we say start on the same day as detoxification starts. And we're looking at continuing to prescribe this for 6 months with regular review, or potentially up to a year, and then even beyond, should that be appropriate. But generally after a year we wouldn't feel the need for continuing to prescribe it if the patient's maintaining abstinence. If a patient relapses to drinking, if it's just a blip, if they just have a brief lapse to drinking, then they can continue acamprosate. It's not going to cause them any harm. But if they continue to drink at a level that they were drinking at before, then it's unlikely that that is going to be beneficial, and we would stop the medication. The dose is usually 666 milligrams 3 times a day. We might reduce this in people that are particularly underweight. And again, just remember that age is a factor, and we shouldn't be giving it for people that are over 65 or under 18. Naltrexone is an opioid antagonist, and it's not licensed for use in the alcohol dependent population, but it is commonly used off license, and it is recommended in the NICE guidelines. It basically acts on the reward pathways, so it reduces the drive to drink when someone's abstained. We would start at a dose of 25 and aim for a maintenance dose of 50 milligrams a day. We do need to make sure that the patient's aware that they can't use other opiates, such as analgesics. And we do need them to have, they shouldn't have impaired liver function either. We would usually prescribe this for up to 6 months or longer if they're benefiting from the drug. It can be prescribed as well as acamprosate, and it's probably useful in patients that find taking lots of drugs, lots of medications in a day difficult. So people that find taking a medication 3 times a day difficult, naltrexone might be a better option for them because it's a once-day dose. And if they are drinking and the drinking persists for a few weeks after starting the drug, then we would stop that medication. Disulfiram or antabuse is second line, but it has a place and it is useful in some patients. But it obviously because of its action, it has got some risks. So we don't advise giving it in patients who have got significant risk of suicide or impulsivity, and patients with cardiovascular disease, for example, significant cardiovascular disease. So basically, alcohol is processed in the liver to acetaldehyde and acetate, and disulfiram works on the aldehyde hydrogenase to reduce its effectiveness, and therefore acetaldehyde builds up when somebody consumes alcohol to a level that causes flushing, tachycardia, hypotension, increased temperature, nausea, vomiting, headache and palpitations. They feel very unwell if they consume alcohol. So historically, people used to get a test dose with some alcohol to feel how that feels, but actually just telling them how they will feel if they do drink is enough to deter people from drinking. So it's not the action of the drug, it's the deterrent of the drug that is actually causing the effect. And then we have nalmefene, which has a different population. We're looking at this in a different population. Nalmefene, again, is an opioid antagonist like naltrexone, but this is licensed for use in patients who have alcohol dependence without withdrawal. So this is used in patients that don't need a detox, who have highly harmful use or dependent use, but they're not getting withdrawal symptoms. And what we do is we give a dose of 18 milligrams a day taken on the days that they're at high risk of drinking, usually taken about 1 to 2 hours before they could predict that they're going to drink. If they do drink before they think about taking the medication, they should take the dose as soon as they can. And because of the effect of nalmefene working on the reward pathways, it reduces the reward of any alcohol they take, and therefore they're less likely to have the second or the third drink if they do have the first drink. So you can use it in those patients that have particularly high-risk days, where they may drink excessive amounts. And it is useful in its place. Again, it should not be prescribed instead of psychosocial interventions. It has to have significant monitoring and psychosocial interventions alongside it. And some people would say that in itself is the bit that's actually working rather than the nalmefene itself. But I think the combination of the medication, the thinking about why you're taking the medication, and the psychosocial interventions and monitoring is where the effect happens. And then we have baclofen. And there's preliminary evidence that this can reduce craving and intake, but evidence is limited. So it's not regularly used. It is used in some sites, but you may see it used. And usually we would be choosing acamprosate, or we would be using naltrexone over baclofen. And it might help with maintaining abstinence, particularly in people that have already been detoxed, so this might be sometime after they've been detoxed. We should start on day one if we can, but there is some evidence to start that on day one, but it's limited, and the evidence is quite limited for baclofen. So we would prefer to use acamprosate as a drug of choice. So in those patients with moderate to severe dependence post-detoxification, we should always be choosing either acamprosate or naltrexone, or both, alongside psychosocial interventions. And antibutyl disulfiram is only offered to those in whom naltrexone or acamprosate is unsuitable, but generally if it's naltrexone or acamprosate is unsuitable, so is disulfiram, but it can be used as well as acamprosate or naltrexone in some patients. And for example, we've used it when we've been treating professionals who might need extra support in the first stages of abstinence. And they need to, with disulfiram, they need to demonstrate that they understand the risks. The risks with disulfiram is that they could consume any alcohol. They could absorb alcohol through aftershaves, or they might consume alcohol in food or something else that they're not necessarily intending to use, and that might create a reaction. So they need to be aware of the risks, and also the risks if they have underlying conditions that might be exacerbated by the symptoms if they do drink. And we need to think about really assessing patients for the appropriateness of all these medications before we even start the detoxification, with appropriate comprehensive medical assessment and investigations. And pharmacotherapy should be the default position, and we should always be prescribing it alongside psychosocial interventions. So it should always be a combination of the two, and not psychosocial interventions alone.